Assalamu alaikum everyone. I'm Aisha Zulfikar and I hope that I find you all in the best of health and you're all doing well. So I welcome all of you on behalf of Giving Back to Pharmacy in Pakistan. And these BCPS preparatory classes is a good initiative to empower all the pharmacists all around the Pakistan. So congratulations to all of you for availing this great opportunity. And today, the topic of our class is very interesting, and it's about anticoagulation. And it will be presented by our respected Dr. Zafar Iqbal. He has done his Pharm.D in 2010, then he passed his PPS exam, and then he passed BCPS in 2019. And currently, he is working as a clinical pharmacist in Armed Forces Hospital, KSA. So, thank you so much, sir, for giving us your precious time out of a tight schedule. We are highly grateful. It's our
Thanks, Ms. Aisha, for your brief introduction. So we will start our topic. Today we will discuss about the anticoagulation. And I don't have any financial and any specific conflict of interest. So we will divide this topic into 5 different portions. First of all is stroke prevention in non-valvular atrial fibrillation, anticoagulation in valvular disease, prevention of venous thrombosis, treatment of venous thrombosis, and reversal of anticoagulation. So first we will see about the stroke prevention in non-valvular atrial fibrillation. Atrial fibrillation is actually a supraventricular tachyarrhythmia in which there is an irregular rhythm of the heart. We will see in briefly what is the pathophysiology of stroke in non-valvular atrial fibrillation and how the thrombus is formed during this process. So as I told you that the atrial fibrillation, when there is an erratic rhythm of the heart, the atria is not completely contracted. Because of this, the blood is not the atria is not completely emptied and the blood is not passed through to the ventricle. So there is a stasis of the blood stasis or takes place in the atria, especially in the atrial appendages as shown in the figure. Because of this blood stasis, the mural thrombus is formed and which may cause the atrial embolization or stroke. Next, we will see the stratification or the risk stratification of the stroke in non-valvular atrial fibrillated patients. Previously, they are using the CHAD scores. Now they updated it to CHAD-VAS scores. So different components of the CHAD scores are congestive heart failure, hypertension, age 75 or above, diabetes, and stroke or transient ischemic attack. But no, they add some more factors like vascular diseases, especially the MI, peripheral artery disease, aortic plaque, age 65 to 74. And they also add the sex category. If the patient is female, there is a 1 point for that sex. According to the CHAD score, we stratified the risk as a low, intermediate, and high. For example, if the score is 0, the patient has low risk of stroke. If the score is 1, the rate is its intermediate category. If 2 and more, then it's a high category. On the basis of the risk category, we also design the pharmacotherapy of that patient. For example, if the patient has a low risk, like 0 in men and 1 in women, it's reasonable to omit any antithrombotic agent or may consider the aspirin for that patient. But if the risk is 1 and 2 in women, 1 in men and 2 in women, that is intermediate category. So we may consider the aspirin in that patient or any anticoagulation agent for that patient. But if the risk is high, so we definitely give the anticoagulation in that patient or may add the aspirin. Next, these are some ACCP guidelines about the atrial fibrillated patient. So first, they recommend that we have to use the CHAD-VAS score to stratify our patient. Secondly, antithrombotic therapy should be given if the patient has, in male, the score is like intermediate patient, 1 in the male, it's 1 or above, in female, 2 and above. Bleeding risk assessment is very important in these patients because the patient are using anticoagulation, so the patient are at high risk of bleeding. So we also have to maintain a balance between the bleeding and our pharmacological agent. So for the bleeding, we use the Hasblad score, especially for the patient which are using the warfarin. We use the Hasblad score. If the patient has the Hasblad score is 3 or above, so patient has high risk of bleeding. Next is they also recommend against the antiplatelet therapy. Like they prefer the anticoagulation. We can add the antiplatelet, but they are not recommended. They recommend against the antiplatelet therapy. So patients which are eligible for oral anticoagulation, they recommend the direct oral anticoagulating agent over the vitamin K antagonist. And if the patient is taking a vitamin K antagonist like a warfarin, so the time in therapeutic range should be more than 65%, like the total duration of the therapy, more than 65% of the duration, the patient INR is within the range, within the recommended range should be. Patient with the atrial fibrillation for more than 48 hours and the patient are going for the elective cardioversion therapy. This elective cardioversion, this is already discussed in detail in the cardiology section, so I am not going in detail. I'm just talking about the anticoagulation in that patients. If the patient has an atrial fibrillation and the more than 48 hours has been passed and the patient is going for elective cardioversion, so it should be recommended to patient should have to take at least 3 weeks of anticoagulation before the cardioversion. And similarly, in the next point, same patient, after the cardioversion, the anticoagulation should be continued for 4 weeks after the cardioversion. Patient with atrial, and the last point, the patient with the atrial fibrillation and ischemic stroke should receive long-term anticoagulation if the patient don't have any high risk of bleeding, so we can continue the anticoagulation in that patient. These are some recommendations for atrial fibrillated patient according to the ACCP guidelines. Next, we will go for the treatment of these patients. First of all, we use the warfarin. Warfarin is the 70 to 80% risk reduction in the stroke and systemic embolism. Many trials shows that the warfarin shows 70 to 80% risk reduction. In that particular patients, we keep the goal of the INR, it should be between 2 and 3. We are usually starting the warfarin dose in the outpatient setting with the 5 milligram, and when the patient is admitted, so we can keep an eye on the patient, so we can start with the 10 milligram, and we can decrease the dose to 2 to 3 if the patient has some comorbid condition, patient has advanced age, low body weight, drug interactions, malnourished patient, and so on. Similarly, for the warfarin therapy, we also know about the various clotting factor and their half-lives. Like clotting factor 7, their half-life is 6 hours, 9, 24 hours, 10, 36 hours, and 2 has the longest half-life of 72 hours. On the basis of the half-life, we know that the INR, when we are monitoring the INR, for example, we monitor the INR today, it will give the value of the dose which the patient took 3 to 4 days ago. So actually the warfarin took 5 to 7 days to to reach that therapeutic level of the INR. So we have to wait, we have to keep in mind these things when we are checking the INR of the warfarin, that this INR of the today's value is giving it's a value of the warfarin dose that the patient took 3 or 4 days before. Similarly, if the patient has the INR more than 4.5, we can hold the 1 or 2 doses of the warfarin and then continue with the reduced dose. If the only single value is out of the range of 0.5, we will continue the same dose, but we will check the patient and we will review the INR after 1 to 2 weeks. If the only one value and that is out of range and the value difference is only 0.1, we will not change the dose, we will continue with the same dose. And similarly, we also have to keep in mind if the INR is decreased to 1.8, because the range I already told you it's between 2 and 3. And if the INR is less than 2 and it's less than 1.8, the risk of stroke is 16% increases. So we also have to keep in mind that we have to keep our INR above 2. And but on the other hand, if the, for example, it's more than 4, it's out of the range and it's more than 4, the bleeding risk is not too much increase. So we have to keep in mind that we will keep our INR around 3, slightly below 3, so it will be within the range. Similarly, the time in therapeutic range, I already informed you that it should be between 65 to 75% of the total therapy duration. The INR should be within the range between 2 to 3. Then we will achieve our goal. If it's out of the range, so we have to modify our therapy or we have to switch to another therapy. Next is the Hasblad score. I already informed you that these are the different factors which we will consider while using, especially with the warfarin therapy, because these factors will give us the risk stratification of the bleeding, like hypertension, renal function, liver function, history of stroke, history of bleeding, labile, INRs, old age, drug and alcoholic excess. So these are the points these are the factors that we will stratify for our risk stratification. The next therapy we will use for these patients is direct oral anticoagulation therapy. These are the 4-agent dabigatran, abixaban, rivaroxaban, and doxaban. And there are some pharmacokinetic factor of these agents. Dabigatran is a factor 2 inhibitor. The remainings are the factor 10A inhibitors. They have the renal clearance, also metabolized through P transport to P glycoprotein transport, also hepatic metabolism. So we also have to keep in mind when we are using these drugs, the other drugs which are using either they are inducer or the inhibitors or P glycoprotein inhibitor or inducer. So we have to keep in mind because they have the interaction with these drugs. According to the other drugs, we have to adjust the dose of our drugs. These are the recommended doses of these drugs and their dose adjustment according to the renal function and the other inhibitor or inducer of the cytochrome P450 or the P glycoprotein. Dabigatran standard dose is 150 twice daily, but if the creatinine clearance is less than 30, and we have to decrease the dose. And if the patient is using any inhibitors, so 50, less than 50, we have to decrease the dose to half. Similarly, the other here the values, if less than 15 dialytic patient, we avoid the dabigatran. Similarly, the rivaroxaban standard dose is 20 milligram once daily, but we have to adjust the dose if less than 50 to 15. We have to adjust the dose. Similarly, strong inhibitor or inducer, we will not use the rivaroxaban. For abixaban, standard dose is 5 milligram twice daily, but we have to decrease the dose. But there, the dose adjustment is on 3 factors. Like if the patient has weight is more than or equal to 80 kg, patient age is more than 80, patient weight is less than 60, or serum creatinine is more than or equal to 1.5 milligram per deciliter. If any of the two criteria is fulfilled, we have to decrease the dose to 2.5 twice daily. Similarly, adoxaban 60 milligram once daily is the standard dose. With the creatinine clearance less than 50, we have to decrease the dose to 30 milligram. Next these are the different trials which are used for these drugs. Relate trials are dabigatran, rocket trial, Aristotle trial, and engage trials. There are some controversies about these drugs, about the trial, because these trials, the population is different in each trial, so we cannot compare one trial, the result of one trial with the another trials. Also, for example, the dabigatran, in the first point, the dabigatran is the only one. All the agent shows the reduction in the ischemic stroke, but the dabigatran is the only one who shows the significance. But the problem with this trial is that this is an unblinded study. So in the unblinded study, the problem is that everybody know which patient is taking the active drug, which patient is taking the control drug. So the more focus is on the patient, on the population which is taking the active drug. So there is a biasness is there. So that's why there is a problem with this study, is that this is unblinded study. Similarly, all agents reduce the mortality 10%, but Bixaban is the only one who achieved the significance. This is maybe because of the Abixaban. You will see that in the Abixaban, the population size is high. But if you will compare, like here, it's 18,000, also dabigatran 18,000, or even the edoxaban is 21,000. But the problem is that abixaban is a two-arm study. It's a control or the active drug. But the edoxaban and the dabigatran, they have a triple arm. They have one control and two active. Like in the dabigatran, one active is using 150 milligram drug, the other active is using 110 milligram of the drug. Similarly, the edoxaban, one active is using 60 milligram of the drug, the other active is using 30 milligram of the drug. So that's why each arm have the less population as compared to the abixaban. And also the lower bleeding rates is shown in the abixaban and edoxaban because their bleeding assessment duration is very less. On the other hand, if you will see the Chadwick score, in Relate trial, the patient has the mean Chadwick score is 2.1. Rocket trials, Devaroxaban 3.5, which is very high. So it means that in this trial, the patient population it's a very critical population. That patient population has higher risk of strokes. So these have more critical patients in that population, but the other 2.1 and 2.8. So on the basis of these, we cannot compare each drug with these drugs with each other because they have this different population. Their patient population characteristics are different on the basis of like CHAD score. So that's why the results are different. Next is the conversions of these drugs, these direct oral anticoagulation to the other parental or oral anticoagulants. So all these four drugs, they can be converted to the other drugs. These things I think so it already discussed in the cardiology section. These conversion you can see there. I think so it should be discussed there. You can just read it on. If any problem you can ask me later on, but I will go to the next topic, next portion. Next therapy is the antiplatelet therapy. Antiplatelet therapy, it's aspirin we are using. There are some studies which showing that the reduction in the risk reduction of stroke with the aspirin. There is one study that is a SPASF study that shows that the benefit of aspirin in reducing the risk of ischemic stroke in patient with non-valvular atrial fibrillation. In these studies, the patient using the dose of 325 milligram per day, and it's effective on the patient population 75 and younger. There is another trial, that is Avros trial, that is comparing the abixaban 5 milligram twice daily, which is a standard dose of abixaban, with the aspirin in those patients with aspirin is using on those patients who are unstable to warfarin therapy. But this trial is stopped early because the abixaban is far better than the aspirin. So that's why they stop the trial early, because they get the benefit from the abixaban. Next is the active W trial and active A trial. Active W trial is comparing the combination of aspirin and clopidogrel with warfarin alone. Aspirin and in this study result, the aspirin and clopidogrel were inferior to warfarin. Warfarin has the better result for the stroke and systemic embolism and MI. So it's the warfarin is better than the aspirin and the clopidogrel, but the major bleeding, that is about the same in both the trial. In active A trial, they compare the aspirin plus clopidogrel with aspirin alone. In this trial, the aspirin and clopidogrel is superior than the aspirin alone, but the bleeding risk is high in the combination group than the aspirin alone. Next is the patient population which need the percutaneous coronary intervention. These patients need the triple therapy. So, and the INR we are using is 2 to 2.5 instead of 2 to 3 in these population. And the aspirin is using, we are using only 81 milligram instead of the higher doses. Clopidogrel is preferred than the other P2Y12 inhibitors. Similarly, the bare metal stent is preferred over the other stents because the risk of bleeding is high. So that's why we are taking these measures in these patients. So WOS trial is compared the triple therapy with the double therapy. Like triple therapy, they use warfarin, clopidogrel, and aspirin. And in the double therapy, they use only warfarin and the clopidogrel without aspirin. What are the endpoint in these studies? The preferred endpoint is the bleeding risk. So bleeding is significantly reduced with the double therapy as compared to the triple therapy. Major bleeding was reduced in 44% in the, and significantly 40% reduction in the major cardiac even in the double therapy with the triple therapy. So it means the double therapy is preferred in than the triple therapy. Similarly, there is another study that is a Pioneer AFPC1 PCI trial. In these, it's for 12-month study. They divided the population into 3 groups. First group is using rivaroxaban plus clopidogrel. Second group is using rivaroxaban, clopidogrel, and aspirin. And after 1 and 6 months, they change rivaroxaban plus aspirin to complete. They stop the clopidogrel actually. Some population, they after 1 month, they stop the clopidogrel. And some population, they after 6 months, they stop the clopidogrel and continue with the rivaroxaban and aspirin. The third group, that is also they start with the triple therapy, warfarin, clopidogrel, and aspirin. And similarly, after 1 and 6 and 12 months, 1 and 6 months, they continue with the warfarin and aspirin, they stop the clopidogrel. They adjust the doses on the basis of the creatinine clearance. So the primary endpoint outcome of the of clinically significant bleeding was significantly lower. So the primary endpoint of this study is also the bleeding. So that is lower in the group 1 than group 2 and even group 3. So the first group is showing less bleeding risk as compared to the other groups. Also, if you will see the other, there is no difference in the composite of cardiovascular death, MI and stroke. So if you will see the MI risk, stroke risk, or cardiovascular death, all the groups is similar. So it means the rivaroxaban plus clopidogrel therapy is preferred over the other therapies. Similarly, there is another study that is a redual trial in which they use the dabigatran plus clopidogrel. First group, they use the 110 milligram twice daily plus clopidogrel for 12 months. Second group, they use 150 milligram twice daily and plus clopidogrel or ticagrelol for 12 months. And third, they use the warfarin plus aspirin and clopidogrel. And aspirin was discontinued after 1 month and 3 months. The patient which are using the bare metal stent, in that patient, they stop the aspirin after 1 month, and the patient which are using the drug-eluting stent, in that population, they stop the aspirin after 3 months. Similarly, here also the primary endpoint is the major and clinically relevant non-major bleeding. That was significantly lower in the first group than the third and second groups. Because here we use the dose is 110 milligram, and here the dabigatran is 150 milligram. So here the bleeding is high as compared to the 110 group 1, but both are better than the third groups. If we will see the ischemic outcomes, MI, stroke, systemic embolism, death, and unplanned revascularization was non-inferior between the groups. Group 1, 15.2%, group 3, 13.4%, and group 2, 11.8%. This one is in group 2, 11.8%, and in group 1, 15.2%. So it means in group 2 is showing better result than the group 1. Here we use the standard dose 150 milligram twice daily, but here we use the less dose, that is 110 milligram. So on the basis of all the trial, the current evidence is showing that rivaroxaban 15 milligram plus clopidogrel or dabigatran 150 milligram twice daily plus clopidogrel is the best evidence treatment in these patients. Next, we have some questions related to the stroke prevention in non-valvular atrial fibrillation topic. So the first question is that the patient BD is 73-year-old patient, height and weight is this, with newly diagnosed non-valvular atrial fibrillation. He also has the history of hypertension, dyslipidemia, stable ischemic heart disease, systolic heart failure. Current medications are aspirin, enalapril, atorvastatin, metoprolol, furosemide, spironolactone, amlodipine. His current heart rate is 72 beats per minute. Blood pressure is 122 by 72. Laboratory values, potassium, serum creatinine, and blood glucose. These are the information they are giving about this patient. So first question is that which best depicts the BD CHAD-VAS score on the basis of these information they are giving. So if anybody can answer about this question, what is the best CHAD-VAS score for this patient? And please write in the chat box if you can write. I will wait for 10 seconds. Yes, I got one answer that is 3. According to that, yes, it's your answer is right that it's 3 because CHAD-VAS score, if you will see, C stand for congestive heart failure. The patient has heart failure, so 1 point we will give here. H stand for hypertension, patient is hypertensive, so 1 point from here. This age is more than or equal to 75, but this patient is less than 75, so we will not give any point here. D stand for diabetes, this patient is non-diabetic, so we will not give any point. S stand for stroke or transient ischemic attack, patient don't have any stroke or transient ischemic attack. V stand for vascular disease, the patient don't have any vascular disease. A stand for age, that is 64 to 75, this patient is coming in this bracket, so 1 point we will give from this point. And S is for sex, for female, but this patient is male, so we will not give any point. So patient, the answer B is correct. The patient CHAD-VAS score is 3 for this patient. So we will move to the next slide. Which statement is more accurate regarding the direct oral anticoagulation therapy for reducing the risk of stroke in patient with non-valvular atrial fibrillation? So for this patient, which statement for the non-valvular atrial fibrillation, which statement is good for correct for the direct oral anticoagulation therapy? First is all of the direct oral anticoagulation significantly reduce ischemic stroke in the phase 3 trial as compared to warfarin. Second is all direct oral anticoagulants significantly reduce the hemorrhagic stroke in phase 3 trial. Third is abixaban is more effective than rivaroxaban because abixaban was superior to warfarin in its total trial, and rivaroxaban was only non-inferior to warfarin in rocket trial. And fourth one is dabigatran was studied in the highest risk patient across the phase 3 trial and should not be used in the patient with CHAD score of less than 2-3. So if anybody can answer this question. So I got the result, two answer D and C. So first we will see the D option. Dabigatran was studied in the higher risk patient across the phase 3 trial. We already see that the more critical and more the highest risk patient the population is in the rocket trial. Their Chadwick score is more than 3, but in the dabigatran I think so it's 2.1. So this option is wrong because this population is not an highest risk population for this trial. So option D is wrong. Secondly, option C, abixaban is more effective than rivaroxaban. This option is also not correct because I already informed you that we cannot compare the result of the two trials because the population size, their characteristics, they are different. So we cannot compare them that one trial has a better result over the other trial. So answer C is also not correct. The answer A is all of the direct oral anticoagulants significantly reduce the ischemic. So I already informed you that they reduce the ischemic stroke, all direct oral anticoagulants in their relative trial, but the significance is showing only in the dabigatran. The other are not significant. So answer A is also wrong. So the remaining is answer B that is correct, that all showing significance in reducing the hemorrhagic stroke. So the answer is B. We will see the next. Next is which is the most appropriate regime for reducing BD risk of stroke. So could anybody answer this question? We have dabigatran 75 mg twice daily, rivaroxaban 20 mg once daily, abixaban 5 mg twice daily, adoxaban 60 mg once daily. I will make it easy for you that the patient creatinine clearance is 40 milligram per deciliter. So 40 milligram per minute. So keep in mind and answer this question. Okay, I got the answer C, which is correct, because the dabigatran is standard dose is 150 milligram twice daily, but here they write it 75 milligram twice daily. So this is wrong. Secondly, the rivaroxaban and adoxaban, we know that these are the standard doses 20 milligram once daily and 60 milligram once daily. But the problem is that when the creatinine clearance is less than 50, we have to reduce the dose. But they didn't reduce the dose here. So this is also incorrect, B and C. So the remaining option is option C, 5 milligram twice daily. That is the correct answer. Next question is the 6 months later, BD needs to undergo percutaneous coronary intervention for the management of coronary artery disease. He has had no medication change and his vital signs and laboratory information remain consistent, which is the best available evidence-based approach to his antithrombotic therapy. Either we will give rivaroxaban plus clopidogrel, abixaban plus clopidogrel, warfarin plus aspirin plus clopidogrel, or adoxaban plus aspirin plus clopidogrel. So what's your recommendation for this question? Anybody answer, please? I got the answer C. Let's see, we will see this C option. As we discussed already that we went for the pioneer trial, the first one with the rivaroxaban, where we use the rivaroxaban plus clopidogrel. Then secondly, we use the rivaroxaban plus clopidogrel plus aspirin for 1 month and 6 months. We update that one. And then the third one is the warfarin plus clopidogrel and aspirin, and we change the dose after 1 month and 6 months. We know that in that trial, the rivaroxaban is the preferred one because they shows the less risk of bleeding. And but the dose there is the 15, I think so 15 milligrams. Just a minute, I will. Yeah, here 15 milligram daily. But here we also know that if the creatinine clearance is less than 50, so we will reduce the dose to 10 milligram. So if you will see in this option, they use the 10 milligram dose plus clopidogrel. So this is the right option. The C option is not correct because there is a high risk of bleeding in that patient. Similarly, abixaban and edoxaban are still not studied in this population, so their trials are under process. So we are not selecting this option. So option A is the correct one. So up till now is the first topic is cleared. Now we will move to the second topic, that is anticoagulation in the valvular disease. First we discuss about the non-valvular. Now we will discuss about the valvular disease. So the risk of thromboembolism is high in the valvular disease as compared to the non-valvular disease. So for the valvular disease, we use the heart valve, bioprosthetic heart valves, or mechanical heart valves. If we will use the bioprosthetic heart valve, the risk is high in the first 3 months. Second thing, the bioprosthetic heart valve, the risk is less as compared to the mechanical heart valve. And the risk of thromboembolism in the mitral valve is high as compared to the aortic valve. So first we will see that if we will transplant the aortic bioprosthetic valve, so the anticoagulation should be with we use the aspirin for 50 to 100 milligram for first 3 months. Warfarin can be used and the INR between 2 to 3, at least 3 months or as long as 6 months if the patient has low risk of bleeding. Next is if we use the transcatheter aortic bioprosthetic valve. Similarly, aspirin we will use and clopidogrel for 6 months and warfarin with the INR value between 2 to 3 for 3 months in low risk patient. Mitral bioprosthetic valve, the preferred therapy is the warfarin, the same INR value for 3 months. And aspirin therapy should be used in addition to warfarin if the patient has the low risk of bleeding. Next, if we will move to the mechanical heart valve. In the mechanical heart valve, the preferred therapy is the warfarin. We will not use the aspirin first. We use the warfarin as a standard therapy, and warfarin we will use as a bridging therapy, because as we know that for warfarin it will take 3 to 5 days to reach the maximum therapeutic level. So until that time, for these 5 days gap, we will fill with the injectable anticoagulant like low molecular weight heparin. We will start with the warfarin and low molecular weight heparin as a bridging therapy. After 5 days, we stop the low molecular weight heparin and continue with the warfarin therapy. For this, the mechanical valve, if we use the aortic mechanical valve, then as warfarin is the preferred therapy, 2 to 3 INR. If the thrombotic risk is high, so we can increase the INR value 2 to 0.5 to 3. Patient with low risk can also use the aspirin therapy, or the patient which using Onyx aortic valve, we decrease the INR value. Similarly, the mitral mechanical heart valve, warfarin for mitral is also high risk, mechanical high risk. So we increase the INR value 2.5 to 3. And if the low risk of bleeding, we can add the aspirin. If patient has both aortic and mitral valve transplant, we use the INR value of 2.5 to 2.3, and we use the warfarin therapy. So now the first case regarding this anticoagulation in the valvular disease. The patient is SD is 62-year-old with the history of significant primary mitral regurgitation. Her electrocardiogram reveals significant leaflet flaring that is not amendable to mitral valve repair. She also has a history of hypertension, dyslipidemia, gout. Current medications are lisinopril, hydrochlorothiazide, simvastatin, allopurinol. Heart rate is given, blood pressure is given, creatinine clearance is given. She is scheduled to undergo valve replacement surgery and will receive a mechanical mitral valve. So this thing, the patient is receiving mechanical and mitral valve. We are discussing the anticoagulation post-operative plan with SD team, which is the optimal regime for preventing thrombosis in this patient. We have 4 options. If anybody can answer, which is the correct one? Yes, I got the answer A. Yes, the answer A is correct, because I told you that for mechanical mitral valve, first of all, the INR should be 2.5 to 3.5. And the second thing is the warfarin is the preferred therapy. So here they are using the warfarin with bridging to the low molecular weight heparin. So this is the right answer. Here they are using the enoxaparin, that is also a prophylactic dose, that is a therapeutic dose. And the goal is not within according to the recommendation. Here also they use the intravenous unfractionated heparin. Their dose is okay, but the INR is not okay. And here they use the warfarin without the bridging therapy, so that is not correct. So answer A is correct. Next is the which statement best describe the thrombotic risk in patient with valve replacement surgery. So if the patient is going for valve replacement surgery, there are different options are given, which is the correct option according. So could you please anybody answer for this question? Would you like to answer this question? So I got 2 options. One is C, one is A. First, we will see the A option. Bioprosthetic valve carry highest risk than the mechanical valve. That is wrong. We already discussed that. Mechanical valve has highest risk than the bioprosthetic valve. So first option is wrong. Second is C. All patients with rheumatic valve disease should receive anticoagulation. This is not recommended that all the patient should need that one. Some patient don't need, some patient needs. So we cannot rely on answer C. Answer B is the higher risk of thrombosis with bioprosthetic valve is during the first year after surgery. That is also wrong, because we already discussed the highest risk is with first 3 months of the surgery, not first 1 year of the surgery after the bioprosthetic valve. So answer B is also wrong. So the remaining is answer D. Valve replacement in the mitral position carried highest risk of thrombosis than the aortic position. So we already discussed that mechanical valve have highest risk than the bioprosthetic valve, and mitral position has highest risk than the aortic position. So answer D is the correct answer. Next is the prevention of venous thrombosis. Venous thrombosis, venous thromboembolism, it's either a DVT, deep venous thrombosis, or either a PE, that pulmonary embolism. So various risk factor for the VTE is that age, surgery, trauma, hypercoagulable state, central venous catheterization, estrogen use, erythropoiesis stimulating agent, previous VTE, cancer, immobility, certain disease condition, smoking, obesity. These are the factors that increase the risk of DVT or PE in the patients. Risk stratification, that if the DVT incidence is less than 10% without thromboprophylaxis, like if the patient is going minor surgery, patient is younger than 40 years, patient is medically ill but fully mobile. For 10 to 40% in those population, patient is going general surgery, open gynecologically or urological surgery, medically ill patient but bed rest or sick, higher risk in major surgery, cancer, hypercoagulable states, hip or knee arthroplasty, major trauma, spinal cord injury. This is also the risk stratification of various population, medically ill patient, less risk, surgery, general surgery, less high risk is in the orthopedic surgery, major trauma, spinal cord injury, and critical care patient. These patients has highest risk of developing the DVT or PE. DVT prophylaxis, we have two strategy for the DVT prophylaxis. One is the mechanical prophylaxis, other is the pharmacological prophylaxis. Mechanical prophylaxis is usually we use the elastic stocking or intermittent pneumatic compression, but this is mostly incompatible patients, incompatible strategy. But we are using mechanical prophylaxis only in that case where we cannot start the pharmacological prophylaxis, as the risk of bleeding is high after the surgery. So up till that time the patient achieve the hemostasis, we start with the mechanical prophylaxis and then we switch to the pharmacological prophylaxis. In the pharmacological prophylaxis, we have different options like low molecular weight heparin, unfractionated heparin, fondaparinux, adjusted dose warfarin, direct oral anticoagulant. Aspirin is questionable, but can be used. Like now, for the orthopedic surgery, in the orthopedic surgery, we use all, like we use the heparin, we use the warfarin, we use the fondaparinux, we use the direct oral anticoagulant. All are recommended. But here we have to consider about the dose and the timing of when to start the our anticoagulation. Like in knee replacement, the dose is 30 milligram twice daily. We should have to initiate 12 to 24 hours after the surgery. Deltaprine, 25,000, 6 to 8 hours after the surgery, and then continue with 5,000. Fondaparinux 2.5 to 2.5 mg, 24 hour, and initiated 6 to 8 hours after the surgery. Similarly, the warfarin, preoperatively or the evening or of the surgical day with adjusted dose, and the INR we have to keep it 2.5 plus minus like 2 to 3. Dabigatran is insufficient evidence in the knee replacement. Rivaroxaban 10 milligram once daily, 6 to 10 hours after the surgery. Similarly, abixaban 2.5 mg twice daily and 12 to 24 hours after the surgery. Similar recommendation in hip replacement, rivaroxaban, dabigatran, warfarin all, fondaparinux all. The hip fracture also same with the knee replacement. But here the hip replacement surgery, we have two options. Either we use 30 milligram twice daily or 40 milligram once daily. And also the deltaprine, either we use 25,000 6 to 8 hours after the surgery, then 5,000 or 5,000 initiated in the evening before the surgery. So these are the options. In the spinal surgery, we preferred the subcutaneous unfractionated heparin or the low molecular weight heparin. So these are the dosing strategies and the timing of the initiation of the anticoagulation in the orthopedic surgery. Next is the non-orthopedic surgery. In the non-orthopedic surgery, the direct oral anticoagulation are not recommended. Heparin and fondaparinux, these are the preferred strategies. Their dosage strategies is heparin unfractionated, if we are using that 5,000 units subcutaneously, Q8 hourly or Q12 hourly. Similarly, enoxaparin 40 mg once daily, deltaprine 5,000 once daily, fondaparinux 2.5 mg subcutaneously once daily. But only in the bariatric surgery, we use the dose like either 12 daily, every 12 hours, the enoxaparin. Deltaprine is also increased and fondaparinux is also increased. Next is the medically ill patients. In the medically ill patients, the VTE risk is lower, but the number of patients are high. If you will see the practical issue, 5,000 every 12 hours or enoxaparin 20 mg once daily is not efficacious as compared to 5,000 every 8 hours or enoxaparin 40 mg daily. These two are the preferred options. They have the similar effect in the medically ill, but enoxaparin shows better protection against VT and less hematoma than the unfractionated heparin. So enoxaparin is preferred option in this. Apixaban, rivaroxaban, they are evaluated in the medically ill patient, but both trials evaluated 6 to 10 days of enoxaparin with 1 month of the apixaban and roxaban. But both the apixaban and rivaroxaban, they have higher risk of bleeding as compared to the enoxaparin, so they are not recommended. So in the medically ill patient, we recommended is the heparin or fondaparinux, and their doses is as here shown here. Next is the extended prophylaxis. As we know that in the medically ill patient, after the discharge, in the immobile patient, the risk of VTE is still there. So we need the extended protection for that patient. So in the studies, when they evaluated the enoxaparin, rivaroxaban, they reduced the VTE, but the risk of bleeding is high with these drugs. So they didn't recommend it. So there is another drug that is bitrixaban, that is specially for the VTE prophylaxis, for the extended prophylaxis. We use this one. The dose of this drug is 160 mg initially and then changed to 80 milligram once daily. Eligibility criteria is patient is 75 year and older, 60 to 74 year, with the 2 additional risk factor or D dimer is 2 times the upper limit of the normal or greater. 40 to 59, history of VTE, history of cancer, additional risk factor or D dimer is more than 2 times the upper limit of the normal. Additional risk factors, it's showing here that if the patient has these additional risk factors, and on the basis of the creatinine clearance NP glycoprotein inhibitor, we have to decrease the dose of bitrixaban. VT prophylaxis in critically ill patient, same, we use the heparin and the fondaparinux. We are not using the direct oral anticoagulation. The direct oral anticoagulants are up till now. We discuss orthopedic, general surgeries, and then the critically ill patient, medically ill patient. Only in the orthopedic surgery prophylaxis we are using the direct oral anticoagulation. Other we are using either heparin or fondaparinux. Indication that how much duration we have to use for clinic medically ill patients, 6 to 14 days, for extended periods 35 to 42 days, major surgery until hospital discharge, major general surgery in patient with previous VTs, we can extend up to 28 hours, up to 28 days after discharge. Similarly, with gastrointestinal or gynecological cancer, extend 28 days more. Knee replacement 10 days, hip replacement, hip fracture 4 to 6 weeks, critically ill patient until the intensive care unit, or we have to reevaluate when we transfer the patient to the critical units or other units. If the patient is still immobile, we will continue that one. Major trauma until hospital discharge, and continue prophylaxis in patient with impaired mobility. If patient cannot move, so we can extend to up to 8 weeks. Patient with the spinal cord injury until hospital discharge, we can extend for 8 weeks. If the uncomplicated complete motor injury, up to 12 weeks until discharge. If the rehabilitation patient with complete motor injury and other high risk factors are there. Special population like patient has renal insufficiency, we already know that we have to adjust the dose of direct oral anticoagulants when the serum creatinine value is changed. So the patient with the serum creatinine more than 2.5 has been included in most of the trial. The problem is that the most of the trial, they didn't include this population with the renal insufficiency with the serum creatinine level is more than 2.5. So first of all, enoxaparin is 30 milligram. We have to give all the population if any indication if the creatinine gain is less than 30 ml. Deltaprine is the preferred drug because it's not affected with the renal insufficiency. We can use that one. Fondaparinux, rivaroxaban, dabigatran, all affected with the creatinine clearance, so we have to adjust the dose. Obesity, usually we increase the dose 40 mg twice daily. is more efficacious than 30 mg twice daily, so we increase the dose. And also for the subcutaneous medicine like enoxaparin, we prefer the abdominal area for injection rather than the thigh area. Also, the one study they suggest that if the BMI is more than 40 kg per meter square, we prefer the low, we increase the dose of low molecular weight heparin. Pregnancy, pregnancy, there is a preferred is the low molecular weight or unfractionated heparin. Low molecular weight are not contraindicated in the third trimester of pregnancy and can be used in the early third trimester. Up till early third trimester, we can use this one. For the if the in the late or peripartum time period, we prefer the unfractionated heparin because they have short half-life. We can easily adjust the bleeding risk in the if there is a bleeding risk in the. Still, the direct oral anticoagulation currently play no role in the pregnancy. So we have the question here. First question is BG is 62-year-old man. Height, weight is given, hospitalized for heart failure exacerbation. He has symptoms when doing one limited exertion and has been out of the bed only to use the bathroom for the past 3 days. His medical history also includes stable ischemic disease, hypertension, diabetes, pulmonary embolism 2 years ago. He's smoking, drinking. His current medication includes bisoprolol, lisinopril, aspirin, ranolazine, furosemide, spironolactone, metformin. Blood pressure is given, heart rate is given, some laboratory values are given, which is the most appropriate VT strategy for BG. So if anybody like to answer this question, we have Fondapanex, we have Abixaban, enoxaparin, and the option is that we know this patient don't need any prophylactic therapy. So for this patient, first of all, we will see the first option, the Fondapanex 5 milligram. Actually, the recommended dose is 2.5. So first option is not correct. If D option, that the risk is the patient don't need any prophylactic therapy, but we see here there are lots of risk factors there. The patient has the history of PE. Patient is smoker. Patient is drinking. So these are the risk factors for PE. So the option D is also not correct. Next is the option B, Abixaban 2.5 mg twice daily and the enoxaparin 40 mg once daily. So here the Abixaban, the patient is hospitalized medically. The patient is medically ill. In the medically ill patient, the Abixaban is not recommended because there is high risk of bleeding in that patient. So we are recommended here in the medically ill patient is enoxaparin, that is 40 milligram once daily as a prophylactic dose. So answer C is the correct one. Dr. Kamran? Dr. Kamran?
Yes, sir.
Yeah. Dr. Kamran, can we continue this one in the next session? Can we arrange this one because still it's already 8 o'clock and still I have some. So if we will divide
if you have some time, sir, and if you are feeling enough, you can continue. Otherwise, if you will say, I will arrange it later also. It's up to you.
Because actually I told you that I am on duty, so I know that they are looking at me, so maybe I have to leave it. So that's why I asked you if you can arrange it.
That's perfectly all right. Perfectly all right, Dr. Zafar. I can understand your situation.
Okay, so inshallah we will the remaining portion we will arrange it later. Whenever you will arrange, I will be available inshallah during the weekends. We can arrange inshallah.
Inshallah, sir. Thank you very much, sir, for your time and
Lord,
your effort.
yeah.
Uh,
If any question you can like ask, and then